Hello, everyone. I'm Muriel Finkel, and on behalf of the ASG, we welcome you all to our amyloidosis webinar that's devoted to amyloidosis with cardiac involvement. You may have noticed that we've resumed some of our in-person local meetings, which can be seen on our website, and we hope to open up meetings in even more cities as the hospitals allow us to do so. Our next meeting is at the City of Hope in Duarte, California on February 17th. We split it up now. We have our ATTR meeting in the morning and our AL meeting in the afternoon, and everyone joins for lunch. Some cities we do it in the reverse. It all depends. If you're on our mailing list or you've joined our Facebook group, you'll be notified about all of our events. And of course, all of our events are posted on our website, amyloidosissupport.org. This webinar is being recorded and will be up on our website and YouTube channel in about 2 weeks, maybe less. For today's webinar, you will not be able to post anything in the chat. Paula will be posting links and other valuable information, and we'll explain how you can save the chat and refer to it at a later time. Speaking of Paula, in the control room today, we have ASG's Executive Director, Paula Schmitt.
Hi, everyone. Thank you for coming.
And our Special Projects Director, Bob Gibson.
Good afternoon, everybody.
We appreciate your emailing in your questions, and they'll be answered by our panel sometime today. We've set aside some extra time to try to get as many answered as possible. As a side note, we're going to have 2 webinars coming up that will be devoted entirely to approved treatments and clinical trial drugs. These are treatments and trial drugs that are offered to our patients in 2024. One will be dedicated to our ATTR patients and the other to AL. We'll get the word out when we have dates available for those 2 events, and we're in the process of updating our treatment charts to reflect the new treatments and trials. Before we proceed, we'd like to have you respond to a short poll coming up on your screen so that we can see the various types of the amyloidosis represented in our attendees today. There we go. Okay, we have 40% AL, 17% hereditary ATTR, 42% wild type, and right now we don't have any other types answering that. Okay, that's very helpful. And we have more and more people joining, some people join late, but this gives us a really good idea and gives our physicians a good idea of what's going on. Thank you so much, Bob. Okay, our presenters today are cardiologist Dr. Melissa Lyle from the Mayo Clinic in Jacksonville, Florida, and Dr. Justin Grodin from the UT Southwestern in Dallas. And I understand he has laryngitis today, so if he sings, we ask that he sound like Rod Stewart, right? And Dr. Barry Trachtenberg of Houston Methodist in Houston, Texas. We'll also hear from our Pharma liaisons, Alexion's Gustavo Bushell, BridgeBio's Mark McGovern, and Intellia's Joy Olberts. There'll be a quick survey when this meeting's over, and we do ask that you please take the time to fill it out. If you have to leave early for any reason, we ask that you fill it out when you leave. It's important to us and helps us in developing future webinars. When I talked to you about our charts earlier, okay, we do have there's the ATTR chart. Paula's going to put a link in that for that chart in our chat, so you'll be able to see it. It's mainly to help you today so that you don't have to figure out how to spell the drugs we also, now that one hasn't been updated yet. The only difference might be the FDA approval of one of those drugs, but basically the 2024 chart's going to look pretty similar. And then we have our AL chart of treatments. You can see we've come a long way on that one, haven't we, over the years? And Paula will put a link in that one as well. Okay. Thank you so much for those charts, Bob. We appreciate that. And now, you didn't come today to hear me. I know that. So we're now going to hear from Dr. Melissa Lyle. Dr. Lyle?
Perfect. Thank you so much, Muriel. It's great to be here. And let me go ahead and just share my screen. All right. Okay, so I'm going to be talking today about heart failure symptoms, just a broad overview, not really getting into specific treatments for AL or TTR, but just how we manage the symptoms of heart failure that might be associated with cardiac amyloid. So this is going to be the outline for my talk. We're going to do a brief review of normal heart function, and then we're going to talk about how amyloid affects the heart. And then we'll review how we treat heart failure related to amyloidosis. So let's start off with normal heart function. So the heart has 4 chambers. It's got 2 receiving chambers, the right atrium, the left atrium, and then 2 pumping chambers, the right ventricle and the left ventricle. And this video depicts how blood circulates through the body. So the deoxygenated or blue blood travels back to the heart by the veins in the body. And you'll see that it follows a tiny blood cell, that blue or deoxygenated blood. Goes back to the veins to the heart, right atrium, to the right ventricle, through the pulmonary artery to the lungs, where it can become oxygenated again. And you can see how the red cell turns blue to red. And then once it becomes oxygenated again, it drains into the left side of the heart, left atrium, left ventricle, and then the left ventricle pumps it out through the aorta to circulate everywhere it needs to go. So that's the normal circulation pattern. Now, how does amyloid affect the heart? So first, let's take a step back. I know a lot of you are very familiar with your diagnosis, but if this is a newer diagnosis to you, let's just review what amyloid is in general. So I like to think of amyloid as an umbrella term. It just refers to a disorder of misfolded proteins. That misfolded precursor protein is then going to aggregate together to form amyloid fibrils. And those amyloid fibrils that our body can't really break down then deposit into different organs and tissues and can cause problems. There's over 35 different proteins in the body that are actually capable of aggregating as those amyloid fibrils. Sometimes we refer to them as amyloidogenic. And the identification of the original precursor protein is pretty crucial because it guides our therapy. And the 2 most common types of amyloid that affect the heart are going to be AL amyloid and ATTR amyloid. So that's what we'll focus on today. However, of course, there are other types, apolipoprotein, other types of amyloid that can affect the heart as well. That A stands for amyloid, and then the rest stands for the precursor protein. So I like to think about the precursor protein and then the protein factory. So what organ makes the specific protein that's causing a problem? So in AL amyloid, the protein is going to be those immunoglobulin light chains. And then the protein factory are going to be the plasma cells in the bone marrow. And in ATTR or transthyretin amyloid, the protein is the carrier protein transthyretin, also known as TTR or prealbumin. And this is a carrier protein. It carries thyroxine or your thyroid hormone, and then holoretinol binding protein or vitamin A. And then the protein factory is largely the liver. So here's a depiction of what happens in AL amyloid. You see the plasma cells in the bone marrow are producing the immunoglobulin, and that's comprised of the heavy chain and the light chain. Dissociates, and then what happens is you get an overproduction of those light chains that then can become misshapen, misfolded, and aggregate into amyloid fibrils. In TTR amyloid, you see that the liver here, the liver cells or hepatocytes are producing this precursor protein, transthyretin or TTR. It's a tetramer, it's a 4-sided protein. When it becomes unstable, it breaks apart into 4 smaller proteins. And those smaller subunits then misfold and aggregate together to form the amyloid fibrils. And that's the rate limiting step of TTR amyloid formation is the dissociation of that 4-sided protein called a tetramer into those 4 smaller subunits or monomers. Now, TTR amyloid is classified by either the presence or absence of an inherited mutation. So if present, that's hereditary TTR amyloid. And if there's no mutation, then that's wild type TTR amyloid. So let's briefly discuss some of the clinical features of the different types of cardiac amyloid a little bit more in detail. So as mentioned, AL, more of a systemic disorder that can have multi-organ involvement. So of course, today we're going to be focusing on the heart failure aspect, but also can have hepatomegaly or liver enlargement, can have nephrotic syndrome, meaning protein in your urine if your kidneys are affected by AL amyloid, can have peripheral neuropathy from the AL amyloid itself, sometimes can also be caused from the chemotherapy, autonomic neuropathy affecting the autonomic nervous system, and then macroglossia is tongue enlargement from the amyloid infiltration, bruising around the eyes and lips, and carpal tunnel syndrome. Hereditary TTR amyloid can have heart failure symptoms and also peripheral neuropathy as well. Now, these are the three most common mutations that we can see. With the V142I or legacy V122I mutation being present in about 3 to 4% of African Americans. Now, wild type TTR amyloid is going to be by far the most common type of amyloid. And this is going to often present as heart failure symptoms, but we have a lot of other red flag symptoms that we can see as well. Bilateral carpal tunnel syndrome, biceps tendon rupture, spinal stenosis, and atrial fibrillation, which can actually be present in about 70% of wild type TTR amyloid patients. And we'll learn a little bit more about atrial fibrillation later today. Now, often the question gets brought up about neuropathy associated with wild type TTR amyloid. And if you ask a lot of the neurologists that specialize in amyloid, they'll say not a true correlation, that we don't typically see neuropathy caused by wild type TTR amyloid. But a lot of our patients do present with those symptoms. And then we've actually even seen post-transplant, we're going to learn from Dr. Trachtenberg a lot more about transplant, but that after heart transplant, we can see further extracardiac manifestations. And we actually had a study from Rochester that highlighted the development of neuropathy in wild type TTR amyloid patients after heart transplant. So I think still more to learn about all of the different ways that the amyloid can affect the body. Now here we're going to focus on the heart though. So this is a normal heart muscle. You see the normal heart squeeze. And then those amyloid fibrils are weaving themselves into the heart muscle to make the heart muscle thicker and stiffer than it should be. And you can see how the heart muscle changes. So again, thicker and stiffer, not pumping as efficiently as it should. Here's a depiction of an AL patient with significant involvement. You can again see the amyloid fibril infiltration, and now you see the light chain toxicity that can happen, that it can actually affect the heart muscle itself, causing cell death just from that light chain toxicity. Now, what happens in heart failure? When the heart muscle becomes thicker and stiffer than it should, you can develop heart failure and fluid can start to back up into your lungs. So the heart isn't able to pump as efficiently as it should. And then the pressure in the heart increases. Blood can back up into the veins that take the blood through the lungs. And as the pressure in those blood vessels increases, the fluid can get pushed out into the air spaces or the alveoli in your lungs, causing that heart failure. And if your doctor describes that you have fluid in your lungs, that's what they're referring to. So what are the specific signs and symptoms of heart failure? Well, some can be nonspecific. So fatigue, shortness of breath, swelling or edema. So swelling in your legs, swelling in your abdomen or belly, being unable to lie down due to shortness of breath. We call that orthopnea. Waking up, gasping for air, or even a cough that's mostly at night. All could be signs or symptoms of heart failure. What are the tests that we use to diagnose cardiac amyloid and help us to determine staging? So the first I want to touch on, and we'll just go through this very briefly before we start talking about how to treat the symptoms of heart failure, but blood tests. What blood tests are often obtained? So typically you're going to have a troponin and a NT-proBNP once there's concern for cardiac amyloid involvement. So with a troponin, this is the protein that's released from the heart muscle, usually due to injury. So this can often happen if someone had a heart attack, but this is increased in patients with cardiac amyloid, not related to a heart attack. Now, the BNP or NT-proBNP, this is a protein in the heart that's released in response to higher pressure in the heart. And this can vary up to 40% over a week. So really, we look more at the trend, and that's much more important to us than a very specific number for that NT-proBNP. And what about the echocardiogram? So this is the ultrasound of the heart. And what are we looking at with the ultrasound? We're looking at wall thickness, the pumping function of the heart, the stiffness of the heart, how the valves of the heart are functioning, and then estimates of pressure in the heart and the lungs. So the first thing that we often see on any sort of echo report is the ejection fraction. So what does that mean? What is the ejection fraction, the pumping function of the heart? Well, it's a percentage. So we're looking at the volume at the start of the cardiac cycle, then the heart squeezes, pumps out an amount of blood volume, and then the volume ejected over the volume out at the start. That's the ejection fraction, that percentage. Normal anywhere from 55 to 65. But let's dive into this a little bit more, because is this an important number in patients with cardiac amyloid? Not really as much as in other types of heart failure. So why is that? So here's three different types of patients. One with a normal heart, normal ejection fraction. Another with a very big dilated weak heart. And then another with an amyloid heart, a stiffer, thicker heart. So the top two examples, this is heart is pumping the exact same amount of blood with each heartbeat, but the ejection fraction is twice as high on the first one as the second one. And why is that? So we see that the second heart has a weak heart muscle. It's a bigger, weaker heart. The ejection fraction is only 30%. The heart has enlarged to compensate though. And so the amount of blood that's actually pumped out still is maintained, even though the heart is weaker. But in this third case, this is a stiffer heart due to amyloid. It's pumping fine, but the smaller ventricle, it doesn't fill as well. And so it's not pumping the same amount of blood with each squeeze of the heart. And so that's important to note, that even though the ejection fraction is 50%, it doesn't mean that that heart is working perfectly normal. So that's why we often don't worry too much about the ejection fraction in cardiac amyloid. One thing that we do use though is strain. So this is a more detailed look at heart function and how the heart is actually twisting and moving. We know that amyloid fibrils can affect more of the base and mid ventricle of the heart, and they often don't affect as much the tip of the heart. And that's what we look at strain. So here you can see the base of the heart, the mid ventricle of the heart, and the very tip of the heart. And this is a depiction of a strain image. So if your physician brings up strain, this is what they're referring to, that it's a depiction of the base of the heart, the mid ventricle, and then right here in the center is the tip of the heart. And typically, because that is moving in a more normal fashion, it's more red. So the more red, the better preserved function. And that's a very typical pattern that we would see in someone with cardiac amyloid. So it gives us a lot of information from the echo report. But what about thick walls? So often your physician may mention how thick your walls are. And does that tell us a direct correlation of how the heart is doing? Well, no, not always. So it's not all about wall thickening. So here's two examples of patients, one with AL amyloid, one with TTR amyloid. And this patient had very severe amyloids and very severe symptoms. And you can see that the walls weren't as thick as opposed to this patient with TTR amyloid, very, very thick walls. You can see how different, these are two similar views in the echoes, but you can see how different their wall thickness is. And this patient was walking 3 miles a day with really minimal symptoms. So now to the big question of how do we treat heart failure related to amyloid? So this is an overview of all of the different options that we have, really with the mainstay of treatment being diuretics or water pills. And we're going to dive into these each separately, but loop diuretics and things like spironolactone, eplerenone, and then we'll talk a little bit about SGLT2 inhibitors. Then we'll briefly touch on other medications that are often used for other types of heart failure and if we should be using those medications in amyloid patients as well. And then once we get into refractory heart failure, meaning very severe symptoms, symptoms at rest that markedly affecting your daily life, then the need for referral for advanced therapies. And Dr. Trachtenberg will be talking about heart transplant, whether LVAD is feasible for amyloid, inotropes, palliative care. But let's go back to diuretics or water pills. So this is all about fluid management and management of volume. Loop diuretics or diuretics water pills are very important for maintaining fluid balance in patients with cardiac amyloid. But it's a delicate balance because we want to relieve congestion, but also we still need to maintain adequate pressure to support a good cardiac output. Lasix is often the first choice, so furosemide or Lasix. I often tend to choose a diuretic with better oral bioavailability, meaning it gets absorbed more consistently. So often I'll reach for torsemide or Bumex. And then what about things called mineralocorticoid receptor antagonists? So these are potassium sparing diuretics, water pills that help you maintain your potassium stores. These can be synergistic and used as kind of an adjunctive therapy for those other diuretics like Bumex or torsemide or Lasix, helping to increase diuresis or get the fluid off, but also keeping the potassium up. And then thiazide diuretics, so this would be metolazone, sometimes HCTZ, or chlorothiazide if you're in the hospital, and these are booster pill diuretics. So they sort of prime the pump to help the other water pills be more efficient. But we have to be very cautious with their use because it can lead to over-diuresis or dehydration, low sodium, low potassium, and kidney problems. And so an important thing to remember too is, do I use metolazone? Absolutely. If someone has maxed out on their Bumex and are also on spironolactone but still struggling with fluid, then metolazone would be a great choice to help. But we have to make sure to still use it sparingly. The duration of action can be 24 to 48 hours. So if you're using it daily, that we try to avoid that because it can have a stacking effect, really affecting the kidneys and causing electrolyte problems with low potassium. Now, going back to this treatment algorithm, so again, patients with a really low ejection fraction. So say you were diagnosed with a low pumping function before you were ever diagnosed with cardiac amyloid, and your doctor told you about all of the medications that can help patients with low pumping functions. Should those medications be continued after you've been diagnosed with amyloid? Well, it's a very good question, and we have to dive into it a little bit more. So this is what we refer to as guideline-directed medical therapy. So in patients with ejection fraction, now this is all heart failure. So these are the patients with those bigger, weaker hearts. We often hear the term guideline-directed medical therapy, and this refers to optimal medical therapy that's been proven to show benefit in patients with heart failure with reduced or mildly reduced ejection fraction. And we often talk about beta blockers like metoprolol, ACE inhibitors like lisinopril, angiotensin receptor blockers like losartan, and ARNIs like Entresto. But are these medications good for patients with amyloid? Well, expert consensus documents tend to recommend against the use of these standard heart failure therapies and amyloid cardiomyopathy, even if patients have a reduced pumping function. And really, it comes down to the fact that most patients don't tolerate these medicines. It can worsen lower blood pressure, fatigue, and dyspnea. So really, they're just difficult to tolerate, and particularly beta blockers. So let's talk about beta blockers a little bit more. Now, this is specifically talking about beta blockers related to heart failure. You'll learn a lot more from Dr. Grodin about the beta blockers using that for rate control for atrial fibrillation. So this is a little different. But beta blockers can be harmful sometimes by reducing the overall cardiac output in a patient who is relatively heart rate dependent. We talked about the lower stroke volume or the lower amount of volume of blood ejected in a cardiac amyloid heart. So the cardiac output in general is the quantity of blood that's pumped by the heart at a given time. That's the stroke volume. And then that's multiplied by your heart rate. So in an amyloid patient with those thicker walls and that smaller ventricle, the quantity of blood that's pumped with each heartbeat is smaller. So if you lower the heart rate too much, patients can have a decrease in their cardiac output and they can feel worse. But again, often we do have to use beta blockers cautiously for rate control to make sure the heart rate doesn't go too high in cases like atrial fibrillation or atrial flutter. And what's the data behind this? Has this been studied? It has. So the use of beta blockers in amyloid actually has been evaluated. Beta blocker therapy seems to be much less tolerated in patients with AL amyloid. And then this specific study found that there was really no association with neurohormonal blockade. That means the broad term of all of those medications with survival in patients with amyloid. And this study focused on TTR amyloid. And the authors actually found that deprescribing or stopping the beta blockers in patients with TTR amyloid was associated with better outcomes. And there was a theoretical benefit thought to be associated with discontinuing it related to that dependency on heart rate and the low stroke volume because of the small cavity. So this study showed that stopping beta blockers was associated with improved survival. So then what about the other medications, ACE inhibitors, lisinopril, losartan, and Entresto? Well, they're often poorly tolerated because of over vasodilation, dropping the blood pressure, and people that have orthostatic hypotension or low blood pressure, particularly when transitioning from sitting to standing. But really, there's not a lot of data on it in amyloid patients. And we've already talked about spironolactone and eplerenone as being helpful in terms of an additional diuretic. But what about in general for amyloid patients? So there was a specific study that looked at a prior study that evaluated spironolactone in heart failure patients. And then they looked specifically at patients that were most likely to have cardiac amyloid based on their echocardiographic features. And there was observed benefit with spironolactone. Actually, there was a reduction in the combined endpoint of cardiovascular death and heart failure hospitalizations. So another indication to really say that medications like spironolactone and eplerenone can be quite helpful. And then finally, there's a lot of buzz about SGLT2 inhibitors for all types of heart failure, and a lot of newer recent trials that have shown benefit in heart failure with preserved ejection fraction. There's a big overlap between heart failure with preserved ejection fraction and cardiac amyloid. And so could these medications be beneficial for amyloid? Well, I think it's still early to say. Most likely, and do I prescribe the SGLT2 inhibitors in my patients? Absolutely, and it often improves their symptoms. But I still think we do need further evidence, and there's been a few retrospective studies, and actually Dr. Matt Maurer in Columbia is doing a prospective study. So I think we'll have the answer to that question, but I find it very helpful in terms of an additional diuretic. So another study looked at conventional heart failure therapies and kind of had some interesting new takes as well. So they looked at prescription patterns, discontinuation rates, and kind of overall prognosis. And over this study period, which was about 27 months, they had 22% of patients on beta blockers were discontinued. 33% of the ACE inhibitors like lisinopril, losartan were discontinued. About 7% of spironolactone, eplerenone were discontinued. Overall, they found again that spironolactone, eplerenone, that combination, those types of medicines were associated with a reduced risk of mortality. The only interesting thing from this study that was different from what we've been talking about is that treatment with low dose beta blockers, very, very low dose, was actually associated with improvement in overall mortality in a subgroup of patients with a really reduced ejection fraction, less than 40%. I think it's still to be determined the overall benefit, but in general, I still think that trying to minimize beta blockers if they were originally prescribed for heart failure is probably going to improve symptoms, and only cautiously using beta blockers in the setting of rate control for atrial fibrillation. But overall, this study really did show that beta blockers, ACE inhibitors were often discontinued because they weren't tolerated, but that spironolactone and eplerenone, that type of medication, rarely discontinued. Most patients did tolerate it, and it was associated with a reduced risk of mortality. Now, amyloid can affect the autonomic nervous system as well, and it can cause orthostatic hypotension, so a form of low blood pressure that happens when you go from standing to sitting. And when recognized, orthostatic hypotension can be treated. How do we treat it? So discontinuation of any potentially aggravating medications if we are over-diuresing the patient. And then also conservative measures. So compression stockings. I find compression stockings very helpful to help with lower extremity swelling, and then also to help with this orthostatic hypotension and keep the blood pressure elevated. If the blood pressure is severely dropping and we're really struggling with autonomic dysfunction, then even having thigh-high compression stockings or abdominal binders can help. And midodrine is a medicine that can be utilized 3 times a day to increase the blood pressure to help minimize some of these symptoms in the setting of orthostatic hypotension and autonomic dysfunction, as well as droxidopa, which is sort of a synthetic norepinephrine precursor, and it's been evaluated specifically in amyloid, in both AL and hereditary TTR amyloid, to combat some of these symptoms of lower blood pressures related to that autonomic nervous system effect of amyloid. So in summary, this is just a brief overview of how amyloid can affect the heart from a heart failure standpoint. We're going to learn a lot more about the arrhythmias, the tachyarrhythmias and bradyarrhythmias. But from a general heart failure standpoint, amyloid can infiltrate and affect the heart, causing heart failure symptoms. It's very important to remember to treat the underlying disease. So we didn't get into the specific treatments for AL and TTR today, but making sure that we're treating that underlying precursor protein, whether with chemotherapy or TTR targeted therapies. Diuretics like Lasix and Bumex and torsemide remain really the mainstay of treatment for that excess fluid buildup. And then if we can, try to minimize beta blockers when possible, but again, it may be needed cautiously for rate control and atrial fibrillation. And thank you so much.
Thank you so much, Dr. Lyle. And Dr. Lyle will be staying with us for our Q&A and our panel. So thank you again. And next we will hear from our doctor, Justin Grodin. Dr. Grodin, are you with us?
Yeah, hi everybody. So this is about as good as my voice gets, but
It's sexy.
Okay. Anyway, so Muriel, thank you so much for the opportunity to speak, and to all the patients that have participated. You know, you are why we do everything that we do, and welcome to all of you. And Dr. Lyle, that was a tour de force. I think all of you at home really had, you know, really a large breadth of information that was just given to you that was all highly valuable. So with that being said, I'm going to share my screen. Okay, I'm going to trust that you can all see my screen.
Yes, it's perfect.
Okay, so the topic that I'm going to go, so first of all, my name is Justin Grodin. I'm a heart failure specialist. I'm a clinical investigator and epidemiologist, and I work at UT Southwestern here in Dallas, Texas. And the topic that I'm going to go over is really a very broad topic, and it's not going to be comprehensive. But really, it's meant to stimulate discussion amongst you, and so that you can ask myself, Dr. Lyle, and Dr. Trachtenberg, you know, different questions that might come up during the Q&A. So, I mean, most, you know, we could probably spend days going over these individual topics. So I have a number of disclosures with drug development and different research endeavors with industry. I also have research funding by both industry, foundation, and the National Institute of Health. Okay, so this is the outline that we're going to go over today, and I do have some hot tea, so I'm going to, this will be a little bit, I'm going to be less long-winded than I usually am. And if any of my patients are in the crowd, you know what I mean by that. So anyway, this is the outline of our discussion. We're going to be discussing arrhythmias. We're going to break them down into those that are caused by fast heart rates. And really, we're going to go over the common ones. This is not going to be comprehensive, but the common ones being atrial fibrillation, atrial flutter. We're going to talk about what those are, and then ventricular tachycardia and what that might mean and what that might be. We'll go over symptoms, treatment for all of those. Then we're also going to break it down and talk about slow heart rates. And some of the common ones that can be experienced by patients with cardiac amyloidosis is sick sinus syndrome and then heart block. And then we're briefly going to touch on pacemakers and defibrillators. And we'll kind of highlight when they might be used, when you might hear some of these terms, if your doctor has recommended them, what the different types may mean and why they might be used and what that might mean for you. So without further ado, I think it's important to go over, why does a patient with cardiac amyloidosis have abnormal heart rhythms? So this is an ultrasound, and you saw a lot of images, a lot of great video in Dr. Lyle's presentation, where you've heard a lot about how amyloidosis can infiltrate the heart. And what you're looking at here on your screen is the 4-chamber view of the heart. And you can see it's characterized by thickening in the ventricles, just like Dr. Lyle had mentioned. And then also we can see that the atria and then the mitral valves are also thickened. So when we think about why do arrhythmias occur, when we know that the ventricles, that is to say the engines of the heart, are involved, and this might cause premature ventricular beats. We're going to talk about what those are, or premature ventricular contractions, ventricular tachycardia, which is a lot of these beats strung together, and then ventricular fibrillation, which we're really not going to get into, and that's not as common with patients with cardiac amyloidosis, but that is an emergency. And then we're going to talk about conduction delays. So why do patients with amyloid have conduction delays? And a lot of this is because there is wiring of the heart muscle, and the extra protein that was depicted in the talk that you had just observed can infiltrate the wiring of the heart muscle and then affect the signals as they get transmitted to the heart muscle. So the signals might not travel as quickly. Now, again, we do, at least there are observational studies that suggest some of these slower heart rates may be more common in ATTR amyloidosis in comparison with AL amyloidosis. And then there really are no data for some of the other rarer types. Now, what is important, and we're going to touch on this quite a bit, is that the atria, these are the loading chambers of the heart, are almost universally involved with amyloid. So in autopsy studies, it is very common to see amyloid infiltration in the atrial tissue. So what does that cause? It causes poor atrial function. So unlike the ventricles, which really beat which contract very vigorously and very strong, the atria in comparison contract much weaker, but they do still have function. And when an atrium has amyloid infiltration, that contraction is not as robust. So this can cause poor atrial function, and it might also cause 2 different abnormal heart rhythms called atrial fibrillation and atrial flutter. And in the coming slides, we're going to talk about what those are. So I think before we get into the weeds of what is an abnormal heartbeat or some of these arrhythmias or abnormal beats, I think it's really important to go over really what is a normal heart rate and rhythm. So what you're looking at on your screen is an EKG, and I don't expect you all to be experts in EKG reading, but I think as we go over each, each abnormal rhythm, it's important that this is going to be a visual depiction of what we're referring to. So, a regular heart rate is really quite wide. This is anything from 60 to 100 beats per minute for an adult. It's very different for children. They tend to have higher heart rates, with infants having the highest. And then when we say the rhythm, this is the timing between each of the beats, and these occur at regular intervals or at regular times. So it's almost like a metronome, okay? So when we look at an EKG, so this is a normal EKG, and what's important to look at, really, that I would like for you all to focus on at home, is that each of these tall spikes refers to a heartbeat. And then EKGs are meant to be read from left to right. And then the horizontal axis is time. So each of these beats is occurring at a regular or equal interval. So this is what we call a regular heartbeat. So an EKG for your doctor is it's an insight into what the heart rate and rhythm is for you or for another patient. So the first arrhythmia that we're going to talk about is atrial fibrillation. And the rate of atrial fibrillation can be irregular and fast. Sometimes it can be very, very fast. We see heart rates anywhere from the 80s to the 120s. And for those of you wearing Apple Watches, this is one of the arrhythmias that your Apple Watch will actually alert you about. And then the rhythm is irregular. We can see irregular timing intervals. Now, if you look at the EKG on your screen, you can see that each of these spikes has really a different distance. There's no kind of metronome-like stable interval in between these heartbeats. So this is a classic electrocardiogram for a patient with atrial fibrillation. So if somebody has atrial fibrillation, now this can be quite common, as I mentioned, in amyloidosis. What are the symptoms? They can be palpitations, which is where you feel like your heart's pitter-pattering, shortness of breath, and if a patient with amyloidosis has heart failure, this can contribute to worsening swelling. So what are some of the treatments? And this is not necessarily exhaustive, but really, our treatments fall into three domains. That is control of the heart rate. Can we get the heart rate slower? And then control of the heartbeat rhythm. In other words, can we make the abnormal, irregular rhythm regular so that it can be beating on a regular interval? And then blood thinning. And we'll talk about what I mean by that. So, when we talk about heart rate control, you've heard a lot about beta blockers. You've heard these are one of the cornerstones of treatment for heart failure for patients without amyloidosis. And you've heard a lot about them from Dr. Lyle and whether or not patients with amyloid can or cannot tolerate those. But largely what we have are beta blockers, and these are medicines that can slow the heart rate. We have a very old medicine that we can use that's called digoxin. This comes from the foxglove plant. This is really uncommonly used. And then theoretically, patients with amyloid may have a very narrow therapeutic window, meaning it might be harder to find the sweet spot of drug effectiveness in a patient with amyloidosis. I can tell you that historically, most people frown when there was use of this drug was discouraged, but used in centers where that manage a lot of patients with amyloidosis, if used carefully, it can be useful. Now, one drug that's very important to recognize is a drug class called the calcium channel blockers. These are very poorly tolerated in patients with amyloidosis and should be avoided. Now, we're not going to be able to go over all of the aspects or all of the drugs that can help control the heart rate rhythm, but some of these are drugs like dofetilide or ticasin or amiodarone. We're going to talk about cardioversion and ablation and anticoagulation in the coming slides. So what do I mean when we're talking about heart rhythm therapy? So as I mentioned, we do have medications, but we also have something called cardioversion. So a cardioversion, unlike the movies, is actually not that dramatic. This is when a small jolt of electricity resets the heart rhythm by changing the electrical polarization of the heart so that it can start beating synchronously. Now, sometimes this is done with what is called a transesophageal echocardiogram. And you can see in the cartoon on your screen that this is an ultrasound of the heart that is done from the esophagus, which is the tube that connects your mouth from the stomach. And then this gives us a really nice window into the back of the heart where blood clots may or may not form. And if there is a blood clot that is present there, then the cardioversion won't necessarily be done. Now, what about ablation? So I'm not an electrophysiologist. I don't do this. But if you follow with a general cardiologist or a heart failure doctor, they might refer you to a specialist that might actually, electrically isolate the areas of the atrium that are causing this abnormal rhythm. Now, we could talk about different techniques. We can talk about the procedures. We could talk about how effective it is, and it varies based on the patient. And there are certain features about patients that may make this more or less useful, but it can be a tool, and it's something we do quite often. So now what about blood thinners? And I think this is very important. So who needs blood thinners? Patients with amyloidosis that have atrial fibrillation that have a low risk of bleeding. That is to say, their risk of bleeding is lower than their risk of having a stroke. This is why we do this. So what do we, So what drugs do we use for stroke prevention in somebody with atrial fibrillation? We use drugs like warfarin, or the brand name is Coumadin, apixaban or Eliquis, rivaroxaban, otherwise known as Xarelto. Again, this is not exhaustive. There are other drugs on the market, but these are the common ones that are being used. So warfarin is a drug that is very, very cheap and inexpensive, and it's been used for decades. But one of the caveats with its use is that we have to make sure that the dose of the drug is causing effective blood thinning, whether it's not too high or not too low. So when patients are starting the drug, they have to get monitored quite frequently to measure the degree of blood thinness, and that's called the INR. So as I mentioned before, why should we do this? We do this for stroke prevention. Now, we do have different risk scores that a lot of cardiologists use to determine somebody's risk of stroke. Now, I want to tell you all, the risk of stroke with atrial fibrillation in a patient with amyloidosis is on average very low, but the risk is high enough to anticoagulate or to put somebody on a blood thinner if they have an irregular heartbeat and they have amyloidosis. So now let's move on to an abnormal rhythm called atrial flutter. So this is quite similar to atrial fibrillation in that it originates in the atrium. The rate, unlike atrial fibrillation, is usually regular. It's anywhere from 140 to 160 beats per minute. It can be faster, it can be slower, but this is what we commonly see. And the rhythm is usually regular. Now, when we look at this EKG, you can see that there is a combination of big spikes and small spikes. These small spikes that look like a sawtooth pattern are what are called flutter waves. And this is actually the top chamber of the heart, or the atrium, that is fluttering. And then every 3 or 4 beats, sometimes 2 beats, we see that one of those signals is translating to a big spike or a complete heartbeat. So what are the symptoms that can cause palpitations, shortness of breath, and worsening swelling? So what are some of the treatments? And you'll see that they're largely very similar to the treatments for atrial fibrillation. We do offer heart rate control. However, it is usually not as effective as it is in atrial flutter as it is for atrial fibrillation. We do offer heartbeat rhythm control, and this tends to be quite effective, but medicines really aren't that useful for this abnormal rhythm, although they can be used. And largely we're talking about cardioversion and ablation. And just like atrial fibrillation, individuals with amyloidosis and atrial flutter do need to be placed on blood thinner. So what are some of the heart rhythm therapies? Again, just like atrial fibrillation, we use cardioversion with or without transesophageal echocardiography. We can do ablation. Now the ablation is different. So the abnormal circuit is on the other side of the heart, and this type of ablation, all they do, if you see in this cartoon, this depicts the electrical circuits. The specialist, or we call them an electrophysiologist, will ablate just a little line and they'll make a little scar, and this will break the cycle that could be curative for this abnormal rhythm. So now we're going to transition very briefly into a different type of heartbeat, and these are those that are generated in the ventricle. So these are the big muscle chambers of the heart. We have PVCs, or premature ventricular contractions, and ventricular tachycardia, which is a string of PVCs. So if you look at the top cartoon, you can see that this is an EKG. We see spikes that represent heartbeats, but we see one that is not identical to the others. And you can see that it's very wide and looks very, very different. That is an extra heartbeat. That is a PVC. These are really, really common in patients with amyloidosis. So I frequently get monitors in my patients that monitor heart rhythm and heart rates, and we do see them very frequently. They are intermittent, meaning that, maybe 1 out of every 50 or 1 out of every 20 heartbeats may be PVCs, and we seldomly don't treat them unless they're symptomatic, which they rarely are, but they can be. Now, what is very different is something called ventricular tachycardia, which is far less common, but this is much more serious. This is when we have a string of PVCs that last for a very long time, typically around 30 seconds or more. So a lot of people can have PVCs and never have ventricular tachycardia. It's important to make that distinction. So what are some of the symptoms? Now, they're largely very similar to atrial fibrillation, palpitations, shortness of breath. They might cause worsening swelling, but this can also cause patients to pass out or to feel lightheaded. Now, the treatment is very different. So we do use heart rate control. It can be somewhat effective. We do use drugs like metoprolol that are beta blockers, but we also really want to try to control the rhythm. In particular, if somebody's got ventricular tachycardia, we can use things like cardioversion or defibrillation. Defibrillation is what's done more so in an emergency. Cardioversion is much more controlled. And then we have medications that are different, medications like amiodarone and mexiletine. So, and this cartoon just depicts that the origin of the abnormal rhythm generates in the thick heart muscle in the ventricles. And this just shows you what an external defibrillator looks like if somebody goes into fast ventricular tachycardia that is a cardiac emergency. So now I want to pivot to slow heartbeats. So the first of which that we're going to discuss is something called sick sinus syndrome. This can be experienced by, it's not uncommon in patients with amyloidosis, probably more common in patients with ATTR, as they're typically on average older than patients with AL. The heartbeats can be both slow and fast. The rhythm can be regular or irregular, and there can be pauses between the heartbeats. And this EKG is a classic EKG that shows you sick sinus syndrome. We see that a lot of these large spikes happen very close together, and this identifies a very fast heartbeat, but then we see these long pauses with no heartbeat, which indicates a very slow heart rate. So symptoms, palpitations, this could be possible, lightheadedness and passing out. Now the treatments are very different than a slow heart rate. So we still want to do heart rate control, but we might stop or lower the dose of the medicines that might slow heart rate. So this could be a reason why, like Dr. Lyle was mentioning, we're backing off of the beta blockers for patients with amyloidosis. And then most of the time, we'll also implant a pacemaker. And this cartoon depicts what that is. I'm not going to go through it in detail because we're going to be discussing it in the coming slides. So so the title of the slide has this is an error. This is an EKG with complete heart block. So what is heart block? Heart block is a very, very slow rhythm. We typically see it more often in ATTR than AL. The heart rates can be very, very slow, typically less than 40 beats per minute. The rhythm can be regular. Sometimes it might be irregular. And what heart block means is that there is a severing of the connection between the top chamber of the heart, the atria, and the ventricles. So the electrical signal that signals the heartbeat is not making the connection. So we see the top chambers and the lower chambers, the ventricles, beating independently from each other. And this EKG demonstrates that. So you see these little waves are beats from the atria, and the big waves are heartbeats from the ventricle. And notice that there are more frequent beats in the atria than there are from the ventricles, and they're not related. So what are some symptoms of complete heart block? Palpitations that are possible, lightheadedness, and passing out. What is the treatment for this one? We can remove offending agents, meaning medicines that might slow heart rates, but largely the treatment is with a pacemaker. So now let's pivot. We're going to end this discussion with a few slides talking about what are pacemakers. And so I'm going to show you some cartoons. I'm going to show you the different types of pacemakers. And then we might talk about some special circumstances where pacemakers might be used. So this is a single chamber pacemaker. This is commonly what we use in the United States. So if you look at this gray device that looks like a big silver dollar with a wire coming out of it, this is placed under the skin in the left chest area. And then there is a lead that travels through the vein all the way down into the right side of the heart. And what a pacemaker does is it just watches the heart rate. If the heart rate goes below a certain heart rate, so let's say 60 beats per minute, the pacemaker might start pacing. When you hear the term single chamber pacemaker, this means that there is one lead in one chamber. And in the United States, it's commonly placed in the right side of the heart in a chamber called the right ventricle. Now, what is commonly used is a dual chamber pacemaker. This is probably the majority of the pacemakers that we implant as cardiologists. Again, very, very similar. You see that there's this silver dollar-like apparatus placed in the left side of the chest. Now, unlike the single lead pacemaker, we see two wires that are coming out of the pacemaker. They go through the veins into the heart, and we see that one of the leads ends in the right atrium, and another lead ends in the right ventricle. And so what's going on now is it can pace in either the top part of the heart or the bottom part of the heart. This is what is most commonly used here in the unit. This is the most commonly implanted type of pacemaker. And now there is a type of pacemaker that I'm making you aware of. It's rarely used in cardiac amyloidosis, but it is called a biventricular pacemaker. And unlike the other two types of pacemakers, this can be done for both normal heart rates or fast or slow heart rates, but largely it is used when the left and the right sides of the heart are not beating in sync, meaning the right side of the heart beats before the left side of the heart beats, and the heart function might be low. This, unlike the others, has 3 wires instead of 2 or 1. And so if you look in the cartoon on your left-hand side, you can see that there are 3 wires, one going into the atrium, one going into the right ventricle, and then another wire that goes around the side of the left ventricle to try to synchronize the heartbeat. Let's see. So, and then I will briefly touch on defibrillators. So these can commonly be paired with pacemakers, but these are devices that will shock the heart in an emergency for somebody that is at high risk for having ventricular tachycardia or an arrhythmia we didn't discuss called ventricular fibrillation. They also can be placed subcutaneously. These don't have pacing functions. So in other words, this is a defibrillator that is placed under the skin in the chest, and then the lead is also tunneled under the skin that can administer a shock to the heart to reset it in an emergency. So this is the outline of our discussion. We discussed arrhythmias, fast heart rates, slow heart rates. I gave you a brief overview of pacemakers and defibrillators, and it was certainly not comprehensive. But I want to thank you all for your attention, and I really look forward to all of your discussion and questions. So thank you for your time.
Thank you so much, Dr. Grodin. You and Dr. Lyle touched on some things that we really needed to hear about. It may take us 3 or 4 times before it sinks in, but thank you. Thank you again. Okay. And now we're going to hear from Dr. Barry Trachtenberg, and then we'll stay tuned for our panel discussion. Dr. Trachtenberg, are you there? You're on mute, of course. Okay, there you go.
Yeah.
And I before we let you give your presentation, I understand you have some big happening in March. Can you share a couple of minutes on that?
Yeah, sure. Yeah, thank you, Muriel. First of all, thank you to you and the Amyloidosis Support Group for inviting me to speak, and to our patients for being here. Yeah, so we have a amyloidosis program at Houston Methodist, and we had a patient who unfortunately passed away while waiting for a heart transplant, and his family wanted to help other people, and they started a program and donated money to start a program at Methodist for amyloid, specifically for research and treatment. And so we had our first annual conference last March, and are looking forward to our second annual conference. So March 1st is for physicians and providers. March 2nd is specifically for patients. And this is the information here. You can see my screen?
I can see your screen. Yeah, if
Okay, perfect.
if
Thank
you
you.
send me a link, we can get that out to everyone that registered today so that if they want to join in.
That would be great. Yeah, we are going to have a virtual option and an in-person option. We'll have guest speakers, and we'll have a lot of Q&A time to ask experts questions that you may not have time to ask your doctor in your regular visit. So there is a link down here. It's very, I couldn't get a shorter version, but we'll get one for you. And I know that we will have representation from the Amyloidosis Support Group at the meeting both days, in which we're very grateful for, and to involve you guys in some discussions with our patients.
We appreciate the invitation, of course.
Yeah, thank you so much, Muriel. So with that, I will be giving a talk on shifting from kind of conventional therapies in cardiac amyloidosis to more advanced therapies, and for patients that are just really not doing well on their amyloid medications and look like they need something more than just medication. So before we talk about, I'll be really focusing on the 2 modalities that we have for patients with advanced heart failure. One is a heart transplant. 2 is a mechanical pump called a left ventricular assist device, or an LVAD. And before we talk about how that looks in an amyloid patient, for background, I want to explain what that looks like in a general heart failure population, so a non-amyloid heart failure patient. So for those who aren't familiar with it, a heart transplant, you're removing the very weak heart out of the patient's body, and you're replacing it with the heart of a deceased donor. And most recipients that are getting a heart transplant are waiting in the hospital, not always, but most of them are waiting in the hospital while they're waiting for a heart transplant. Typically, they're supported with a mix of either IV medications or temporary mechanical support devices like a balloon pump or Impella, or sometimes ECMO, which is like a heart-lung machine. And patients after transplant, they need to be on medications for life that are suppressing their own immune system and keeping it from attacking the heart, which is not their own. And those medications do have side effects. And so you are in some ways trading one disease for another, but one with a much better survival and much better quality of life. So on average, in 2024, if you get a heart transplant, in the United States, you're looking at about a 90% chance of being alive at 1 year after the transplant. At 5 years, you're about 75% chance of being alive after the transplant. And on average, about 12 years survival after a heart transplant in the modern era. If you survive that first year, what we call the conditional survival, average is about 14 years. So some patients, longer, we have patients up to 25, 30 years. Those are, the minority, but we do have patients that make it that long after transplant, but the average is about 12 years. And sometimes we need 2 organs. Sometimes we need a heart and a kidney, a heart and a liver, and less commonly a heart and a lung. But those are increasingly done in the modern age. So the other option we have for patients is a left ventricular assist device. So this is a mechanical heart pump that's placed with open chest surgery that is being placed in the heart. So you have this pump that is basically taking blood out of the weak left ventricle, and you see this this graft here going from the heart to the aorta. So it's sucking blood and it's pumping it to the aorta so that the body can get blood flow to the rest of the heart. And then it has this little cable you can see that comes out of the skin attached to a controller, and it attaches to batteries, which typically last 12 to 14 hours on average. And so some patients will get this assist device, this LVAD, and get it while they're waiting for a heart transplant, and they'll go home with that and wait for a heart transplant. And some patients will get this instead of a heart transplant. For example, they might be too old for a heart transplant. They might have what's a pulmonary hypertension, or high blood pressure in their arteries, so their lungs that are too high, and a heart transplant won't take, so they need to have an LVAD first. Or they may have other conditions that would make them ineligible for transplant, or they may not want a transplant and may opt for just this device. With the newer pumps that we have, the average 5-year survival is now approximately 60%, compared to about 75% for a heart transplant. So much better than it had been 5, 10, 20 years ago. And when we compare these two options, we have to look at the advantages and disadvantages of each. And all of this also takes into account the individual patient and what their specific comorbidities, wishes are, and of course taking that into account. Advantages of the LVAD is namely that you don't have to wait for a heart transplant. There's not a heart transplant. In the United States, this year was a watershed amount of heart transplants, over 4,000. Typically, it's been 3,500 a year. So this is, that's limited by the amount of donors that we have. So still, even with 4,000 plus, very, very small amount compared to the patients that have advanced heart failure and could benefit from a transplant. So with LVAD, you don't have to wait. You don't have to wait for an organ to be available. You have an off-the-shelf device you can take and put in the patient. Age is not a limiting factor. We have patients in their 80s that have LVADs and do very well. And patients get significant improvement in their heart failure symptoms. And rarely, depending on how hard you try and depending on a lot of factors, you could have improvement of the native heart with an LVAD, where you actually take out the LVAD after some time and the heart improves. In the real world, this happens about 1% of the time. In trials where they've really pushed to try to make this happen, it's happened maybe as high as 10, 15% of the time. But those are the advantages of the LVAD. And the disadvantages of the LVAD are, if you have heart failure in both your ventricles, where the right side of the heart is really, really weak and dilated and not performing well, then the LVAD sometimes may not be enough, and the patient may have, still have bad heart failure from the right side of the ventricle. And that's sometimes difficult to predict. There's bleeding risk. Patients on an LVAD do need to be on Coumadin for life. And they also have a risk of having strokes every year with the LVAD. Because there's a cable that comes out of the skin, and that is susceptible to infections, and so they could have dry blood infections that can be difficult to eradicate because you have a foreign body inside your body that's coming out through the skin. And again, we're talking about the general population. We're not talking about amyloid yet necessarily. And for transplant, the advantage is, one, it's fully implanted. You're not having any external devices coming out that are susceptible to infection. The survival, even though the LVAD survival is still is much better than it used to be, and is improving with each device evolution that we have. Transplant still has a longer survival and has better data for 5-10 years plus. Disadvantages of the transplant: you do require lifelong immunosuppression, and these medications have side effects. They can cause infections. You can have rejection despite being on the immunosuppression medications. Some of these medications can cause cancers long term, and renal failure, and hypertension, and diabetes. Another disadvantage is, we talked about the scarcity of organs, but also the risk of dying while you're on the wait list. Sometimes the average wait list for transplant varies depending on your blood type and where you live and how sick you are and what devices you're on to support you. But typically patients wait months in the hospital, and you might, if they're getting worse, that you can't just grab a transplant when you need it. You have to wait till it comes to you. Whereas an LVAD you can grab off the shelf. And I know Dr. Lyle talked about this, but just as we think about transplanting a heart for AL amyloid, you have to think about the fact that AL amyloid is a systemic disease. The bone marrow produces these light chains that form these amyloid fibrils, and it goes into all these organs. You can see the heart's affected, over 80% of the time, kidney affected over 60% of the time, and then you have other organs that are involved as well. Nervous system, liver, GI, of course, as well. So when you think about transplant, you have to think, how bad are these other organs, and what's going to happen after transplant? And when we think about amyloid patients, we talk. So the United Network for Organ Sharing has data for keeps the data for survival and waitlist mortality and all these things for our transplant patients. If you look at the risk of dying on the wait list, you can see amyloid in yellow compared to an idiopathic restrictive cardiomyopathy, which is similar, shape of the heart compared to amyloid, but not amyloid, or dilated cardiomyopathy, where you saw those pictures before by both Dr. Lyle and Dr. Grodin's presentations of a dilated big heart. And you can see that the risk of dying on the wait list for amyloid is 3 to 4 times higher than the risk of dilated cardiomyopathy. So partly because of that, amyloid does get automatically a little bit higher status on the new updated waitlist criteria. There's 6 levels you can be at. 1 is the sickest and highest level you can be at, and those patients tend to get organs quicker because they're higher on the list. And amyloid, and some of this is dictated by what kind of medications you're on, what kind of devices are you supported with, and amyloid gets a little bit higher to status 4, regardless of how they're supported, or even if they're not on IV medications. But keep in mind that most patients that are transplanted are status 2 or 3 and not status 4 or 5 or 6. So when we look at heart transplant with AL amyloid in particular, this was really, the initial experience with this was not good. 1, a lot of patients died on the wait list. 2, there was a very high rate of recurrence of amyloid after heart transplant. For example, Mayo Clinic reported their early experience with transplant with AL amyloid, and they had a 1-year survival of about 77% compared to approximately 90% in this day and age, to a 5-year survival of 43% compared to 75% more or less for non-amyloid patients. Mass General reported a waitlist mortality of 35%, very, very high, 3 to 4-fold higher at least than the average waitlist mortality for non-amyloid patients. So why was the initial experience so bad? Is a large part is because of the agents we now have to treat AL amyloid. Certainly, bortezomib was a big game changer, and even since then, now agents like daratumumab and other immunotherapies have even changed the game even more so, that we're able to keep keep the amyloid at bay before a heart transplant if we have time to get patients on chemo. And also after a heart transplant, we're able to keep it from coming back more effectively due to the current chemotherapies that we have. Other reasons why the outcomes have improved, better patient selection. I think we're getting a little bit smarter about knowing which patients we can get through and which patients may not. Stem cell transplant, I put plus or minus, we can talk about this, but the data for stem cell transplant and survival is not clear in the general population. Certainly, we have less data just due to numbers in an amyloid population, but perhaps that's one factor. And then using temporary mechanical support to improve waitlist survival, I think has also been a factor in helping us get patients to transplant. So this is a paper published last year showing just looking at how do we assess eligibility for heart transplant in patients with cardiac amyloid. So I think the first thing we have to decide is, one, is the heart sick enough? And this is a little bit more challenging in patients with AL amyloid compared to TTR and then non-amyloid patients to figure out if the heart's sick enough, because if with AL amyloid, things can happen quickly and patients can deteriorate very quickly. So sometimes we have a lower threshold to get patients on the wait list for transplant, even if we're not going to actively transplant them immediately. So the first thing you're asking is the heart sick enough? These are the kind of the conventional things that we ask of all patients that we're considering for heart transplant in general, not just amyloid. So are the patients coming into the hospital for heart failure, multiple times? Are they on IV medications to support their heart? Are they very limited in what they can do? Are they short of breath at rest, or doing very minimal activities? Looking at a metabolic stress test and the parameters that we use on that. Are they on super high dose of diuretics just to maintain their normal fluid status? Are they having deterioration in their kidneys or liver or other organs? And then we have some staging systems for amyloid that we use to help guide us for that as well. And then just as importantly, in terms of eligibility for transplant, you have to ask, is the rest of the body well enough? How frail is the patient? How bad is the neuropathy? Because the neuropathy may not get better after transplant. It may get worse due to the progression of disease and some of the medications we use for immunosuppression. How are the lungs? Is there pleural involvement of the lining outside the lungs? Is that involved? Is there a current fluid outside the lung that's not just due to heart failure, which can be challenging to predict? And GI disease, is the patient have significant malabsorption where they're losing weight and not able to keep their protein levels up? The kidneys, of course, and are they losing protein in the kidneys? Is their kidney function poor? And the protein in the urine is a lot of different programs have different cutoffs for how much protein is acceptable before you consider transplant, because that may not get better with the kidney transplant. However, now with new medications like daratumumab, that might get better just with chemotherapy, but it might take 6 months or a year to determine that, and you may not have that kind of time to assess. And then what kind of hematological response does the patient have? This is also another controversial area, because some programs will necessitate that they have a very good response to their chemotherapy before you can put them on the list, because you don't want to take someone with active production of amyloid to transplant. But on the other hand, sometimes you have a patient that's in cardiogenic shock or in the hospital, and they're not well enough to go home, and they don't have that kind of time to assess. This is just an example, just to kind of look at the approach that we have had at Houston Methodist, where you start the patient on chemotherapy, and then you do a heart transplant. After heart transplant, you may continue with chemotherapy depending on what kind of response they've had prior, but certainly surveillance. And then this is the controversial area of a stem cell transplant. It used to be, the reason why we started doing AL amyloid transplants is because we had stem cell transplant as an option, and you could give some chemo. This is before we had great chemotherapy options, but we could give chemo and then do a heart transplant. And then most programs would do a stem cell transplant about 6 months after the heart transplant. We opted to do it for various reasons at about 12 months after heart transplant. And but now, we're not necessarily doing it in all patients. We used to do it, routinely in all patients that we could, unless they had a reason not to. And now, because we have so much good chemo and immunotherapy, we're still trying to sort out the role for stem cell transplant after a heart transplant. So this is our experience that we published several years ago. But just to give you an idea, at least at one program, how things might look. So we had 42 patients that we evaluated for transplant, and we didn't list 18 of them. 24 we listed, and 2 patients died on the wait list, and 22 received a heart transplant, 18 for AL, 9 for transthyretin amyloid. And you can see we had several multi-organ patients. Now, 5 years later, we've had 44 transplants for amyloid, 26 for AL, 16 for ATTR, and many of these were for multi-organ. And just to show you, the data for the modern era of what you can do with AL amyloid, whereas before, even with transplant, the outcomes were poor. And you can see from some of the older data here from Mayo and Mass General, this is really before they had great chemotherapies. You can see the survival, 1 year, 77, 61, 5 year, 43% at Mayo. This is, older data in a different era. And now looking at our program, looking at Heidelberg, which is from a German program, and Stanford and Cedars-Sinai, certainly other programs have reported their outcomes that have been more in line with what we see from our non-amyloid programs. So if you look at the 5 year survival we reported from our patients that were for light chain amyloid, and you look at the Heidelberg, they also had a 75% predicted 5 year survival. And you can see that if you look at the Heidelberg data, they had their first era from 2002 to 2007. Their second era was from 2008 to 2017. That's really when proteasome inhibitors became available. You can see a big part of that survival difference. 94% of their patients in their second era were on proteasome inhibitors. That's like Velcade or bortezomib, whereas only 6% when their 5 year survival is 31%. So nowadays, we are looking at data with immunotherapy. Certainly, we'll be looking forward to the CAL data. But there's so much more hope and so much more evidence now that in carefully selected patients, of course, not every patient with AL amyloid can get a heart transplant, but ones that can have the survival that's equivalent to patients that don't have amyloid, which is really remarkable. Now, looking at transthyretin amyloidosis, so we don't think of it as systemic like we do AL, but it really does involve so many organs, especially the nervous system and obviously the orthopedic symptoms as well. But you can see because of the way it involves the nervous system, it can involve the GI system and the autonomic nervous system of the gut, and it can also involve the kidney, and although less commonly than AL. And so transplant for ATTR is, before we had any therapies directed for ATTR, before 2017, really the approach was just, transplant patients if they had this disease. That was the only option, except for the patients that were, too old for that program, usually most commonly over 70 or some programs 65. And because the liver is the main source of the ATTR protein, about 95% of the TTR we make in our bodies made from the liver was typically transplanted along with the heart. So patients would have both a heart and a liver transplant. You could have a domino liver transplant, in which you take the liver out of the patient, of the recipient that has transthyretin, and you give it to a patient on an alternate wait list for a liver that may not otherwise get a liver transplant. And typically, you ask, well, why would you give someone a liver that might make transthyretin and give them another disease? Is because typically those patients won't live long if they did not get a transplant, and they might not start making ATTR in that new liver for many years, if not a decade or two sometimes. So now that we have, we do have therapies now that can significantly decrease your production of TTR, and so because of that, a lot of programs are shifting from doing a heart liver transplant to doing just a heart transplant in patients that have advanced heart failure with TTR amyloid, and are doing RNA therapies, including silencers or stabilizers after transplant. So although there are still some programs that are doing combined heart liver transplants for the hereditary patients. Now, this is a very fascinating and difficult concept to understand, but we're often asked, are we done with TTR amyloid after transplant? Even if you say a patient had a heart liver transplant, do we have to worry about TTR after that? And unfortunately, we still do. There's a process known as seeding, where your native body, your native liver will, if there's any amyloid in your body, your body will sense that, and you'll produce wild type TTR in your new liver. And that could be independent of whether you had hereditary wild type to begin with, but you can make new wild type TTR after a liver and or heart transplant. So we know that a lot of patients that do have progressive symptoms outside the heart, especially neuropathy after a heart transplant, we've seen this well described in patients that had liver transplant for polyneuropathy without heart failure as well. So we still do, unfortunately, have a need to have formal surveillance and treatment of TTR to limit the progression of these symptoms outside the heart, and then so that we can maintain quality of life in patients that have had a heart transplant for ATTR cardiomyopathy. And then just looking at ways we approach patients waiting for heart transplant, we have to first of all, similar to what we showed before, look at if the patient need a transplant, what are the contraindications, are there any reasons why they cannot have a transplant, is it, do we need to consider multi-organ? And then if these patients are candidates for transplant, we have to evaluate, do they have, how bad is their right ventricle? Can we get by with supporting them with just a device that helps with their left ventricle? So we have, this is an example on the left, you see Impella in the heart. That's a temporary mechanical device that now we often use up in the chest and the axillary artery so patients can ambulate while they're waiting for transplant. The second picture on the right is a patient that has an intra-aortic balloon pump, which was devised to be in the groin and go up to the aorta through the groin. And this, now we've been able to devise it to kind of turn it upside down and put it in the chest so that patients can walk and be supported while they're waiting. But sometimes patients with amyloid, especially light chain amyloid, need biventricular support while they're waiting and may have a harder time supporting with just these devices. And just to touch briefly on LVADs and amyloid, this is not commonly done, and to show you why, if you see the cartoon, you can see the normal heart on the top left. On the top right, you see the dilated heart. That is a typical patient we put an LVAD in. And at the bottom right, you see restrictive cardiomyopathy, which is amyloid is a type example of that, although it can also look like hypertrophic cardiomyopathy as well. You see the picture on the right that's moving. That is an amyloid heart, very thick. And you can see the picture, the still picture is an ultrasound where you have the cannula of the LVAD showed in a dilated heart. So in that dilated heart, that cannula has plenty of room to take the blood in without getting abutting against the native heart. If you look at the picture on the right, you can imagine if you put that cannula in there, it would kind of get trapped in a native heart because it's so thick, full of amyloid, and it won't work as well, and it maybe have more risk of blood clots. So Dr. Grodin and colleagues took a look at this. They looked at data from a large database of LVAD patients and looked at patients with amyloid, patients that had other types of restrictive cardiomyopathy, so similar shaped hearts, but not amyloid, and then patients with the dilated heart, with a bigger heart, which is the more common patient we put the LVADs in. And you can see the death rate in the black line from the graph shows is much higher risk of death with amyloid in an LVAD compared to non-amyloid patients. In addition to the higher mortality rate, patients with amyloid patients with an LVAD, higher likelihood to have strokes, infections, kidney failure, and bleeding compared to the conventional LVAD patients. So they just didn't do as well. There's a case series from Cleveland Clinic where they describe 5 amyloid patients who did get an LVAD, and 4 out of those 5, they actually had surgery to remove some of the thick wall of the heart before they put the LVAD in. They did report that this is feasible. At least there was 100% 1-year survival. The median survival was 2 years on device. And of course, this is very limited, early findings, 5 patients. We don't know their long-term outcomes yet, but very interesting concept. And just to wrap up, these are some of the remaining, these are just a few of the remaining controversy questions that we have. Dr. Lyle and Grodin and I can debate all of these for hours, I'm sure. One is, should we have stem cell transplant routinely for post-heart transplants for light chain? We don't know the answer to that. What kind of response to AL should we have? For hematological response, should we mandate, if any, before listening for heart? How much proteinuria is too much to make the kidneys not too high risk to do a transplant? How much neuropathy is too much in patients that have a lot of autonomic neuropathy and they're on lots of medications to augment their blood pressure, like the droxidopa and midodrine? We worry about how they're going to do with general anesthesia waiting during a heart transplant. And should we still be doing liver transplants for hereditary ATTR? And then what's better post-transplant? Just stabilizer, silencer? These are just some of the few questions that we don't have answers to. So just to wrap up, and I'll be happy to answer questions along with Dr. Lyle and Dr. Grodin. Heart and heart multi-organ transplants are options for select patients, and outcomes in these patients can be comparable to patients that are transplanted for other indications. Post-transplant, we do continue chemotherapy if needed, plus or minus a stem cell transplant. Post-TTR, we do consider TTR-directed therapies to minimize progression of TTR outside the heart, especially in the nerves. And LVADs may be an option in the future as devices are smaller, hopefully in the future, but currently the outcomes are not great. And with that, I'll hand the mic back to Muriel and appreciate the attention.
Thank you so much, Dr. Trachtenberg and Dr. Lyle, Dr. Grodin. We'll have you on our panel now. What was so great about your presentations is all 3 of you, at least from my point of view, address things that have never been addressed to patients before, so it was really good from patients' perspective to hear all these things. It was quite a learning experience, and a reminder to everyone that we will have these videos up on our YouTube channel and our website as soon as we can get them up. Okay. Before we get to the questions, since we have the 3 of you, and Dr. Trachtenberg said, well, some of us, the 3 of us could debate some of these things for hours, and we don't want you to debate things for hours, but Dr. Lyle, Dr. Grodin, Dr. Trachtenberg, is there anything that you heard one of your colleagues say today that stood out in your mind? And if you were in a class, you would have raised your hand and said, teacher, teacher. And is there anything that, you might have a different opinion on or something? So let's have your mics on and hear what you have to say. And don't be afraid.
Yeah, I mean, I think Dr. Lyle did a really nice job about the goal-directed medical therapy in amyloid. And I think she put it perfectly in terms of looking at the data and especially with beta blockers. And I agree with everything she said, but just so I can spark some conversation here. I do use beta blockers sparingly, but sometimes, as she said, and as Dr. Grodin said for arrhythmias, sometimes you have to use it for patients that are tachycardic, and some patients are really hypertensive, and you have to choose one agent for that. And there's a lot of agents you want to avoid. So it is controversial, and I think we certainly need more data to say that before we start taking away beta blockers based on the trial that she showed. I don't think she was suggesting that, but that is an area that we certainly, it's hard to have the gold standard randomized controlled trials in this population, and we lack that in a lot of this, so that we have to rely on a lot of these retrospective trials. But so again, no issue with it. It's just that just I think is probably one of the most challenging parts of treatment, and perhaps the most controversial.
Dr. Lyle?
Yeah, I would like to add, on to what Barry said and point out one thing, and I think Dr. Lyle, excuse me, alluded to very, very well. But when we look at that observational cohort study from Europe that shows that patients with beta blocker use had better survival, I think it's very different to say that beta blocker use was associated with better survival in comparison with improving survival. Those are two very different things. So it is very likely that in that study, because these patients were already treated, that the reasons they were on beta blockers made them lower risk in comparison with those that could not tolerate those drugs. So I think that's something to point out, and it really influences how all of us think about these treatments in patients with ATTR or AL amyloid.
Okay, Dr. Lyle?
Yeah, no, absolutely. I think it is, it's very controversial. And I always, the standard response is that we need to always do this as a case by case for what the patient's needs are, what they're tolerating. If someone had been on a beta blocker that had been started for hypertension or something like that, then that obviously we were wanting to kind of cautiously see if we can decrease it. But I think it's a case by case, and it is quite controversial, and we just don't have the data yet, or maybe ever, to be able to have a definitive answer.
Yeah, I mean, if I don't think it's bothering my patient, I might leave them on it if I think there's a compelling reason to be on it. But I think if there are clear reasons not to be on it, or I'm suspicious that they're getting side effects, then I'm going to back off.
And with beta blockers, is that where the one that you mentioned where it lowers their blood pressure? So, and with orthostatic hypotension, which a lot of our patients have, and I think that was Dr. Amar when he made his presentation, that was his big point, that he didn't like them because of the lowered blood pressure, but that doesn't seem to bother you guys quite as much.
No, I think, I mean, at least for me, it definitely is a concern, and that's why, not just the orthostatic hypotension, but lowering the heart rate if they have a risk of having too slow a heart rate. There's a lot of reasons we try to avoid it or cautious if we have to use it. So I'm not saying that we should use it, regularly. I'm just saying sometimes we do need to use it, and our hand is forced. And so that's just the challenging aspect of it. I don't know, Dr. Lyle.
Yeah, no, I mean, I agree 100%, Barry. I mean, it's just, patients can present so differently. If you have a patient with a good amount of blood pressure and maybe not a ton of cardiac involvement, but horrible atrial fibrillation with, rates in the 130s, they haven't tolerated antiarrhythmics, we're going to need a beta blocker to help with rate control. But then if you have someone who's been on this, is feeling fatigued, tired, has a low stroke volume, I cautiously will try to decrease it. And then if they tell me I'm feeling a lot better, then we'll keep trying to decrease it to discontinue. So it's just kind of a case by case.
Yeah, and on average, we see that patients with ATTR, some of them might actually be or have high blood pressure and then can tolerate a lot of stuff.
And that's a great point, Justin, because
Yeah.
I didn't go into that. I kind of
Yeah.
talked about, the ACE inhibitors, the ARBs, but you're right. We have tons of wild type TTR patients that I have on lisinopril because if I tried to stop that, their blood pressure would skyrocket. So it kind of depends on the phenotype of the patient.
But for those people that Melissa was talking about that might need midodrine or droxidopa, that's somebody where we would be very, very cautious, or really would not, where these drugs would not be attractive to use.
And Dr. Lyle, Dr. Trachtenberg talked about LVADs and transplants, and Dr. Lyle, do you do heart transplants there at the Mayo in Jacksonville?
We do. We're actually the fifth largest transplant center this year. So we do, and we actually have a lot of amyloid patients that we transplant. So 100% agree with everything that Dr. Trachtenberg said. It's important to think about these patients who have failed therapy otherwise, that they need to be evaluated for advanced therapies. And absolutely, I think some of the most interesting things are exactly what he touched upon, is how do we manage these patients post-transplant? The two big areas of concern are the pre-transplant selection, just like he went into, making sure that you don't have other organ involvement that's going to be a contraindication to transplant, but then kind of moving into after the transplant, how do we manage them? So for AL patients, what do we do if they have a recurrence or a relapse? Is stem cell appropriate? And all of those are great questions that are still great questions, as Dr. Trachtenberg emphasized. And then I think for, it's really interesting in the TTR world, how do we manage those extra cardiac manifestations with the use of silencers and stabilizers? What is the best way to continue to monitor them and utilize therapy post? So absolutely, it's a really kind of exciting area. He highlighted everything so nicely.
Okay, great. Any comments before we get to some questions? Okay, and we see this one a lot. People want to know, when can they get back to their previous exercise routines, and how much exercise is enough, or is there such a thing as too much? So Dr. Lyle, since you're on the screen, we'll let you go first.
Yeah, I think it's a great question. And of course, it kind of depends on the specific patient as well. But often I still kind of recommend the typical recommendations for exercise, that more moderate intensity exercise. We want to make sure that patients aren't exercising to the point of exhaustion. That's where I start to become a little bit more concerned. Now, if someone has just been diagnosed with AL and is kind of going through their chemotherapy, I might be a little bit more cautious. But if it's a wild type TTR patient just diagnosed, I would have the same exercise recommendations that I would for most patients.
Okay, Dr. Grodin, this question here, does achieving remission, so we'll say that this is probably an AL patient, okay, does achieving remission lead to a lessening of cardiac arrhythmias and other heart conduction problems?
That's a great question. So, and we could probably spend 30 minutes talking about whether or not that could happen, and if so, why might that be? So, when we think about untreated AL amyloid, as Melissa highlighted, the light chains are toxic to the heart muscle, but there's also amyloid that is infiltrated the muscle itself. So it's very common that as the light chains improve, we see that a lot of the blood tests that we measure that indicate the severity of the heart disease get better as well. But yet when we image the hearts, they might look the same. So there is a thought that biochemically something is going on more favorable in the heart as AL is being treated. So in short, I would expect that arrhythmias would improve. I can tell you our center, one of our practices, and I'd be interested to hear what Melissa and Barry do, but we get a lot of monitors in these people. In particular, patients with AL will get a 30-day event monitor, because what we're really looking for are dangerous or irregular heartbeats for those that might need a defibrillator or those that might need other treatments. But what's very interesting is we we might repeat those on an annual basis, and there is no textbook that tells us what to do. We just try to keep our patients healthy and safe and feeling well. But we commonly see those early on before treatment, don't always see them, once they've achieved remission, but that doesn't mean they don't occur when we're not looking. But my suspicion is that they do get better, but there's always an underlying risk for them.
We should have had a hematologist on the panel just to validate that. Any comments, Dr. Lyle?
Yeah, I just agree 100%. So I typically do annual monitoring, Holter 30-day. I also have a low threshold to do a loop if I'm concerned as well. So especially, with our AL patients, but then also the hereditary patients if I'm worried about progressive conduction abnormalities. So I do a lot of monitoring for sure.
Dr. Trachtenberg?
I agree with that. And I also, like Dr. Lyle said, I have a low threshold to do a loop recorder, especially if they're advanced AL amyloid, but don't meet criteria for defibrillator, whatever that is, by the way. Low threshold for annual monitoring for someone that's stable, and a loop recorder for someone that I'm a little more worried about.
We have a lot of questions, which we're not going to answer today, about the end of life, last 6 months of life. I think we'll skip that for today, but I will ask you, doctors. I'll send you the questions, and you can maybe put down some comments, and we'll answer those patients specifically on them, because some of the questions that they've asked are rather personal. Okay, and go into detail. Okay. Here's a question for you, Dr. Trachtenberg. What effect does amyloidosis have on the blood flow to the lower extremities, specifically the lower back, legs, and the knees, and possible effects on ED? That would be, I guess, erectile dysfunction, I'm thinking. Is there any remedy or help to alleviate the pain?
Yeah. So, I mean, we don't have, it's not clear in that situation if it's, two separate diseases or if it's the neuropathy. I mean, certainly amyloid, the neuropathy might be contributing to a lot of those symptoms in terms of, causing arterial disease that can cause blockages in the arteries. It's certainly feasible, but we don't have data that that's happening. So, for that patient, I would say needs a good assessment of both neuropathy and of his or her vascular tree down the leg. So,
Dr. Lyle, Dr. Grodin, you have anything to add?
Oh, I don't.
No, I agree.
Dr. Grodin? No? Okay. We had a couple of questions on this. And this one is for hereditary amyloidosis, but we had one on AL as well. Does amyloidosis affect a person's eyes? And we had another one about, does it affect hearing? So let's just go with all the senses and see and get all of your opinions on the amyloidosis affecting the senses, okay? Dr. Grodin?
Sure. So that's a hard question to answer. And so, I think, I don't know if it was Barry or Melissa highlighted, at least in TTR amyloidosis, one thing that I teach when I'm on rounds with residents or fellows is that the amyloid in the heart is made in the liver, right? So Melissa talked about the factories of amyloid. There is a little amyloid that is made in a small organ in the brain, and then in a part of the eye called the retinal epithelium. So if somebody's got wild type ATTR, that largely the TTR that's made in the brain doesn't get into the blood because of the blood-brain barrier, and the TTR that's made in the liver doesn't go to the brain or the eye because of the blood-brain barrier. So if they've got wild type ATTR, largely we really don't think that there is any central neurological involvement or eye involvement. However, when we look at observational studies, we do see that there is an association with cataracts. Now, that is probably guilty by association and maybe not biologically linked. With hereditary ATTR, then we get into the weeds of what is the specific mutation. So there are mutations that, in theory, can affect the eyes. These tend to be those that affect the nerves more so than the heart, and might affect people at younger ages, where the amyloid can affect not only parts of the brain or the central nervous system, and we call that type of amyloid leptomeningeal involvement, where we're getting, some of the big nerves are being involved. It's very uncommon. It's very, very rare. A lot of the treatments that we use don't necessarily cross the blood-brain barrier, with the exception of something that was on your slide earlier called tolcapone, which this is off-label. It's uncertain how useful it is, and it does have side effects that need to be monitored.
And that was for TTR amyloidosis. What about AL? Do we see any effect on the eyes or in the hearing or any of the senses with the AL?
I'll let one of my colleagues answer just to give my throat a break.
Okay, we'll give his throat a break. Dr. Trachtenberg?
Yeah, I mean, in terms of hearing, I know for hereditary, there is some data for ATTRs, and not a lot of data, but certainly data that it can affect hearing loss in some patients. And AL amyloid, I'm honestly not sure about hearing loss. I don't know if anything, I don't know if Dr. Lyle or Dr. Grodin are aware, but certainly for the eyes, there's, all types of amyloid can affect the eyes in various ways. And so there certainly are ocular manifestations of amyloid that need to be monitored if you're having symptoms, I should say.
Agree, could have vitreal deposits, but I'm not sure about the hearing loss with AL either, unless Dr. Grodin, I'll let his voice rest, but unless he knows, I haven't heard that as much for AL.
Okay, while we have you on the screen, Dr. Lyle. Okay, this person has ATTR, had a heart transplant last July, now is being considered for a kidney transplant due to a new protocol. Now, we didn't go into the fact that when your heart is sick, it can affect your kidneys, and when your kidney is sick, it can affect your heart. And, but this person says they're being considered for a kidney transplant due to a new protocol. I don't know. By the way, I do have stage 3 CKD, chronic kidney disease, CKD.
Yep.
Okay.
So, yeah, perfect. So I think that Dr. Trachtenberg kind of touched on the fact that for TTR, less likely to affect the kidneys from an amyloid standpoint, but we can have that effect just from an overall heart and kidney relationship that we kind of refer to as cardiorenal. So we can have the kidneys affected in that standpoint. And then also post-heart transplant, some of the medications that we utilize, like the calcineurin inhibitors, can affect the kidneys. And so people do have, especially if they had kidney dysfunction going into transplant, maybe the hope was that the kidneys would improve with a new heart, but maybe they didn't improve, especially with the addition of our medications. Maybe they're referring to the safety net policy in terms of the new policy, meaning that someone who has a heart transplant originally might have been considered for heart kidney, but with a new safety net policy being able to have patients prioritize within the year after heart transplant, only do a heart, see if the kidneys improve. If they don't improve and there's still a need for kidney transplant. So it's not unreasonable that patient, if their physicians feel that the kidneys aren't going to recover, to be considered for kidney transplant in that scenario.
I agree. And one thing I would add is remember that, as people age, with AL perhaps less so, but with ATTR certainly, as people age, we can collect problems that are not amyloid related that might also affect kidney function. And so we do see those as well in patients with amyloidosis. So like diabetes, high blood pressure can all affect kidney function. And they might all be strange bedfellows where, that one might make the other worse.
Okay. This person wants to know if amyloidosis, some of this we know, but I think it's worth repeating. Can it affect your bowel tract, causing diarrhea and constipation? Can it cause neuropathy or severe pain and numbness in the feet? Can it affect your eating habits? So Dr. Grodin, we'll give your throat a rest a little bit. Okay, Dr. Trachtenberg?
I'll rest my throat by simply replying yes.
There you go.
And yes,
okay.
It covers all those things.
Yes to all those. Okay. Here's an interesting question. Before Before I was diagnosed with amyloidosis, I was diagnosed with Raynaud's syndrome, which continues today with purple fingers and sometimes toes. And I usually feel cold. My question is, could Raynaud's be a precursor to ATTR wild type? And if so, should testing have been done to catch this at the early stage? Raynaud's? Any? No?
I mean, I'll just at this point in time, there's no link that's associated. They're thought to be independent entities. Raynaud's may be associated with some autoimmune disorders, but oftentimes it's benign and isolated. So I wouldn't say that someone should have been thinking about amyloid just because someone had Raynaud's.
Hey, Dr. Grodin? Dr. Lyle?
Yeah, I agree. I think there's no known association. I mean, we know that patients with amyloidosis may have hot or cold intolerance, but whether that's misconstrued as Raynaud's or overlaps, as far as it directly being caused, I'm not sure that we know the answer to that.
Agree.
Okay. Okay. What about hoarseness when speaking? This is a wild type person asking this, but we hear a lot about hoarseness. Dr. Grodin, we know you're hoarse, but it's not due to amyloid, we hope. But and we always hear about a cough too, associated cough. So let's discuss cough and hoarseness. Dr. Lyle?
Yeah, so for the cough, briefly in terms of heart failure symptoms, sometimes that could be a sign of heart failure if you're having additional fluid buildup and we need to diurese and improve the congestion. That cough, especially at night, is one thing that we can see from a heart failure standpoint. In terms of hoarseness, I think that's a little tough because also we want to make sure that we're not ruling out other causes of the hoarseness too. But I don't know if Dr. Trachtenberg, and we'll let Dr. Grodin rest his hoarseness, but
Yeah, no, I agree. Hoarseness, I mean, it could be so many things. I mean, if some patients with really bad heart failure, they can get, the heart can kind of enlarge and impinge on the recurrent laryngeal nerve, which can cause some hoarseness. So that is rare, but that can sometimes cause hoarseness in a patient that has a lot of heart failure. But otherwise, yeah, I mean, if it's amyloid can go into those nerves as well and cause hoarseness. It's certainly possible, but like Dr. Lyle said, I'd also make sure that that's excluding other diseases before we presume it's amyloid, but it's certainly feasible. Yes.
Okay, so it wouldn't be like amyloid in the laryngeal part of the.
It can. I mean, it could. I mean, theoretically, it could be in the nerve, in the laryngeal nerve, whether it's in the actual larynx. I mean, I'm sure. For light chain amyloid, I mean, that's, I would imagine that's not uncommon for it to deposit. But for TTR, most likely, I would imagine it would be the nerve if it's causing that.
Yeah, I will add, we've focused mostly on ATTR and AL in this discussion, but APOA1 amyloidosis can be found in the larynx. So it can cause amyloidomas in the voice box. Again, that's uncommon. I don't know if anybody is on this session that has that, but so it would be one unusual or less common circumstance where that might occur.
Right. We did invite our APOs, we have an APO group on Facebook, and we did invite them to come, but they would come if they have cardiac involvement. I would think that would be why they would have joined. Okay, but thank you. Okay, what we're going to do is we're going to give your throat a break for 10 minutes, Dr. Grodin. We're going to give everyone a break for 10 minutes. And then when we come back, we'll continue with our panel discussion and financial aid, and we'll hear from Pharma. So see you all in 10 minutes. Before we get back to our esteemed panel, Paula, our executive director and financial aid guru, is going to give us a real quickie presentation on any financial aid that's available right now or that might be available in the future. So Paula Schmitt, take it away.
Well, good afternoon, everyone. While Bob pulls up my slides, I'm going to direct you on how to look at some of the links that I have posted for you already in the chat. If you take your mouse down toward the bottom of your viewing screen, you should have a menu bar that pops up, and there you can click chat. You will then see the links that I have posted already for you to use to find some of this financial assistance that I'm going to be talking about. And if you would like to save the chat where you can print it out later, if you go down to the bottom of the chat window, the bottom right-hand corner, you'll see 3 small dots. And if you click on those dots, the top thing that it says is save chat. You can click on that and just know where you're saving it to on your computer so you can go back and find it. But that is a way that you can access that information later on after the webinar has closed. But now we will get to the patient support that is out there. Next slide, please. Now, every one of our pharmaceutical companies has some type of a patient assistance program that you may or may not qualify for financially. We do encourage you to contact each one of the whichever pharmaceutical company it is that you're taking their drug. Contact them at any one of these links that's posted, depending on your medicine, and talk to them. They have staff that is available for you. They will answer your questions. They can give you information on their financial criteria that they have in order for you to apply for possibly free drug with them. Now, they may tell you that before you can apply with them, that you have to apply with one of the financial assistance foundations that are out there. Now, next slide, please. And there are several that are out there that you can apply with first to see if their funds are open. If those funds are not open, you can then go back to the pharmaceutical folks and tell them that, you know, you'd have either been turned down or that their fund is not open for the financial assistance foundations. Healthwell Foundation has 2 different funds. They have a fund for amyloidosis and they have a fund for cardiomyopathy. The cardiomyopathy fund, I've watched it closely over the last year, and it tends to stay open a lot. So that's a very good one to try to apply for. It's also worth more than the amyloidosis fund. It's up to $10,000 per year, but you do have to be on Medicare in order to qualify for that fund. If you're not old enough yet, you do have to wait for the amyloid fund to open up. Patient Access Network, or more widely known as PAN Foundation, also has a fund. Now, they did reduce the amount this year that they have available, but that is because of the reduction in the annual out-of-pocket that people will have to pay for their drugs this year because of the Affordable Care Act. The Leukemia and Lymphoma Society also lowered the amount of copay assistance that they offer each year. But the good thing about that is both of those organizations are now going to be able to have more money to give out to more patients. So hopefully those funds, when they do open up, they won't, run out of funds as quickly. But the poverty level rate is 500% for most of these. The Leukemia and Lymphoma Society, that is for patients that have AL amyloidosis along with myeloma or some other associated type of blood cancer. Could be Waldenstrom's, B-cell lymphoma, anything like that. But you can contact them. They have a higher poverty level rate. They go by the 600% threshold. So you can make even a little bit more money each year and qualify for that fund. You do need to contact all of these companies. If the funds are not open right now, please do sign up for their waiting lists, because that is how you will find out when that fund opens back up. Some of these funds will actually email you and say, we are now accepting applications for new patients, or we are accepting applications for renewal patients. So when you get that email, jump on it. You've got to be quick on this because these funds go quickly. I cannot emphasize that enough. These funds may only be open for a day or two when they do open back up. So have your tax forms from the previous year handy where you can get at them quickly. So if you get that email, you can apply quickly. Next slide. This chart shows you the financial assistance thresholds for 2024. The amounts did go up a little bit. So the good news is you can make a little bit more money each year and still possibly qualify for financial assistance. Say, for instance, a household of 2 people, for someone, most of these are paying 500%, so you can make $102,200 a year and qualify for the financial assistance, as long as the drug you're on is listed as being covered by that fund. And they do cover most all of our drugs for AL and for TTR amyloid. So that's a bit better news. And if you live in Alaska or Hawaii, you have a higher cost of living, so that threshold goes up a bit for those people. Also, if you live in, say, New York City or LA, some larger city that has a higher cost of living, don't necessarily just go by the chart. Call the organization that you're trying to get the funds from and see what level of poverty rate that they're going by on that, because sometimes when it is a larger city, they're going to allow a higher amount of income for that particular area because the rates are so much higher there for cost of living. Next slide, please. The Fund Finder app that is given out, that is that was founded by the Pan Foundation. This is another good thing that you can sign up for. It will send you an email alerting you to when a fund has opened up. You'll see a chart like what I have here on the screen, and see on the right-hand side, you see the little green lock that's open. That shows that the Leukemia and Lymphoma Society is currently accepting applications at the moment for our myeloma and blood cancer patients. The other funds were closed at the time that I did this. This is actually an old screenshot, but if you go in and you sign up and you tell them which disease fund you are interested in, and you will receive emails saying this fund is open, you can now apply. So again, sign up for everything that you can, sign up for all the wait lists. They may not be open today, but they could open back up next week. There were 2 funds that were open earlier in this week, but they have closed. But again, the Healthwell Foundation, that cardiomyopathy fund, is open and accepting applications. So as long as you are on Medicare, you can apply for that right now. And that is basically my presentation. If you have any questions, you can always email me at paula@amyloidosissupport.org, and I'll do what I can to help you try to figure it out. I can help you find out which ones are open or not open at that time. So thank you very much.
Thank you, Paula. Now everyone knows why Paula is everyone's best friend, right? So thank you so much. Okay. Well, I'd like to have our doctors again, Dr. Grodin, Lyle, and Trachtenberg. We'll just do a couple of questions, then we'll let our pharmacists do their presentations, and then we'll come back to more questions. We do have questions relating to treatments, but we're going to stay away from most of those. We will try and have our doctors answer them via email for us, but right now we're going to focus on some other things. Doctors, the patient just wrote in, is Metropol 200 milligrams daily cause for concern? Remind us what Metropol is, and then answer that question. We'll let Dr. Lyle answer that.
So that's metoprolol is one of the beta blockers so that we were talking about. So without knowing the specifics of the patient scenario. Hard to say. It's a high dose. That would be our maximum dose, but not necessarily if it's used for rate control and the patient is tolerating it, doesn't necessarily mean that it's cause for concern. But it is a high dose of a beta blocker. But I'm sure that there's a good reason why their physician might have them on that higher dose if it's utilized for rate control.
Okay. And Dr. Trachtenberg, do you agree with that?
100%.
Okay, great. Okay, here's a question. And we received several of this about their treatments, whether it be for ATTR or AL. When their treatments cause irregular heartbeats, what should they do? I mean, to me, a layperson, I would say change treatments, but I mean, is there something special that's done when a treatment, let's say daratumumab, causes an irregular heartbeat?
I think the big challenge with this, Muriel, is that patients with amyloidosis can have irregular heartbeats that might occur in parallel to their treatments, where the treatments might appear to be causal, but they're really just more overlapping. So I think it's case by case. Because those treatments are so beneficial, obviously with AL and ATTR, there's different mechanisms. We really don't think any treatment with ATTR causes arrhythmias. That might not be so clear with AL, but it would be pretty unusual. But especially for AL, because we know that they're so beneficial, my threshold to change life-saving therapy is pretty high, unless there's a pretty compelling reason or a compelling toxicity that would be keeping us from doing that.
Okay. If this patient wants to, is oxygen ever considered to help with shortness of breath?
I mean, only if the oxygen level is low enough that it meets the necessity to have oxygen, and that has to be determined usually by a pulmonologist.
Okay. Okay, and okay, let's see. Another Metropol question. Evidently, Metropol is okay. All right. Well, let's take a pass on the questions for now, and let's let our let's hear from our pharmaceutical people that are going to be talking about some trials, and then we'll get back to our doctors. So we'll give you guys a rest again. Okay. So there you go. Dr. Lyle, do you plan on having the Centellia trial going on at your joint?
I think to be determined in the future.
And what do you think about the Bridge Bio asymptomatic trial?
No, I think it's really exciting. So, I mean, all of the trials, great presentations, really exciting. The landscape is obviously rapidly changing, and I think we're all super excited to see what the future holds.
Do you think you'll have that Bridge Bio trial, or are you
I mean, we would love to participate. So
there you go. And what about you, Dr. Trachtenberg? How do you feel about the Bridge Bio?
Yeah, it's exciting. I think it's an important trial that's looking at it from a different perspective, and one that certainly needs to happen, so we can focus on more prevention than treating at a later stage of diagnosis.
And Dr. Grodin?
Yeah, I mean, I think you're looking at 3 clinical trials that are all really trying to address crucial questions in really unique, transformative ways. So this is, really exciting time. And I mean, kudos to everybody at these companies for putting these together. And yes, we're obviously delighted at the opportunity to participate in all 3. And so we'll see what happens.
That reminds me, we got a question sent in earlier from someone, and it addressed the asymptomatic thing, and that is if someone has been considered asymptomatic for their particular variant, should they have a PYP scan and it shows amyloidosis in the heart, even though that particular variant isn't noted for cardiac involvement, would you consider them their disease active? Would you start them on a treatment based on that?
Yeah, I mean, I think if they have a variant that's known to cause cardiomyopathy, if they're asymptomatic and the PYP is positive, and it's a good quality study, then yes, I would start them on treatment. If the question is if they have a variant that is not known to cause cardiomyopathy and they have a PYP positive, I would pause a little bit and look a little bit deeper at their symptoms and study them a little bit further. It may require additional testing before I start treatment.
Dr. Grodin?
I agree with Barry. I mean, I think, the first thing is that a lot of people will do PYP scans, but not everybody does them well. So I think that's crucial to make sure it is a good quality test. But my practice patterns are very similar to Barry's.
Dr. Lyle?
Agree 100%. But I think that that's an important point, that we have to make sure about the quality of the PYP and that it's not a false positive. So routinely, if the PYP has been done elsewhere, I'll make sure that I have the images sent to me so I can review it myself.
Okay, great. Do our panelists have any other questions of these pharmaceutical companies while we have them here? Any questions of each other? Well, we've gone a little over. Okay, we do have quite a few questions that weren't answered, but that's because they're kind of more specific to that particular patient and not necessarily of general information. So what we'll ask that you answer some of those. And again, specific treatment questions will be answered at the next two webinars that we have. We have one coming up for AL and one coming up for ATTR. And I want to thank everyone so much for taking part in this. It was a unique webinar. I think we learned a lot about the heart that we didn't know before. And we just want to thank everyone. So thank you so much. And please, patients, make sure that you fill out the survey at the end of this. It's so helpful and we really need that. Okay, thank you, everyone.